Welcome back to the deep dive. For many decades, if you were performing a total knee arthroplasty, you were really relying on implants that were designed for one specific demographic.
Right, the Western knee.
Exactly. But now we're seeing this just exponential surge in TKA demand across Asian populations. We're talking India, China, Korea, Japan.
And it presents a massive surgical puzzle.
It's more than a puzzle, isn't it? It's like a fundamental mismatch.
It's a crisis of geometric mismatch, is what it is. We can't keep using components that were developed, over 5 decades based on the morphology of white populations and just expect them to work.
And give optimal outcomes.
The anatomical realities, the functional requirements, they're all profoundly and, measurably different.
And this is about physics and geometry, not just cultural sensitivity. I love the analogy we use in training.
Formula One car.
Yeah, the Formula One car. You're trying to tune this high-performance machine, the Asian knee, which is designed for extreme articulation with, like, standard street tires.
It looks okay on the surface.
Right, it holds air, it'll roll, but the kinematics just won't hold up when you ask the patient to actually hit the track and, squat down every single day.
Exactly. And the differences are measurable, from bone density all the way down to the rotational alignment you need.
So our mission today is to really unpack that science.
Right. We're going to dive into the demographic, the kinematic, and the morphologic data that defines this Asian knee profile. We'll be looking at the tables and figures in our source material and talking about how we, as surgeons, have to adapt.
Okay, so let's start at the foundation, the patient population and how their disease presents. I mean, it's just so different from a standard rotation in, say, North America.
It is, and the sheer disparity in the osteoarthritis ratio is where you have to begin.
The OA ratio skew.
It dictates everything. In Asia, the hip-to-knee osteoarthritis ratio is a remarkable 1:9.
1:9.
For every 1 hip you do, you are doing 9 knees. Now, compare that with white populations, where that ratio is more like 1:2, maybe 1:3.
That fundamentally changes everything. If I'm training in Seoul versus Seattle, my case exposure, my entire focus is just completely shifted to the knee.
Precisely. It tells you that knee pathology is the overwhelmingly dominant orthopedic problem. And it's likely multifactorial, genetics, plus that high-demand floor-based lifestyle.
Which puts massive repetitive stress on the joint from childhood.
From childhood. And that skew carries right into the gender demographics, too. The gap is much wider in Asia.
So what are we seeing there?
The male-female ratio for knee OA needing a TKA is about 1:4.
1:4. Compared to what in the West?
Compared to roughly 1 to 1.5 in white populations. This fourfold predominance in women needing a knee replacement is massive.
And it points to other unique factors, right? Like osteoporosis, maybe body fat distribution.
All of it. Plus, the leaves-long burden of floor-based chores, which often falls disproportionately on women. And on top of that, these patients are often dealing with significant systemic health challenges.
You mean metabolic syndrome?
Absolutely. Metabolic syndrome, so BMI over 30, hypertension, diabetes. It's a huge risk factor for OA. And the incidence is reported as 2 times higher in Asian TKA patients.
2 times higher. So you're starting with a patient who has poorer vascularity, higher infection risk, just compromise healing right out of the gate.
Right. And sadly, these complex patients often present extremely late.
Which just compounds the surgical difficulty.
It's a common observation, but it seems exacerbated here. Studies show Asian populations often wait until their knee function has just deteriorated far worse than what we typically see in the West.
They tolerate more pain.
It seems so. Until the deformity is catastrophic. We frequently see these severe varus deformities with a massive medial tibial defect.
Like we see in figure 25.1.
Exactly. I mean, you look at that figure, you're seeing knees with OA for more than 10 years. These aren't just simple osteophytes. These are major bone deficiencies that require augments, bone grafting, a whole different plan.
So complex patients, late-stage disease, and major bone defects. That brings us right to the quality of the bone itself.
The soft foundation. This point cannot be overstated. The substrate matters.
And what does the data show?
Asian populations have the lowest peak bone mineral density, or BMD, globally, particularly when you compare them to Afro-Caribbean or white populations. For example, BMD in Indian women can be 25 to 30% lower than American European scores.
A quarter to a third less dense. That's like trying to secure a screw in softwood versus hardwood.
That's a perfect analogy. It's a fundamentally softer foundation for your cement and your implant. And it's often complicated by widespread nutritional issues.
Specifically vitamin D deficiency.
Rampant vitamin D deficiency. We see it reported in so many Asian countries. and this leads to osteomalacia in adults.
And what's the classic orthopedic manifestation we see from that?
Skeletal deformity, genies varum or ginovalgum. Varus knee is a main manifestation of osteomalacia, and that starts the vicious cycle.
The weak bone leads to deformity, and the deformity then just accelerates the arthritis.
It's the biomechanical loop that seals the knee's fate. We even had the numbers on it.
Right, I remember this. Even a small increase in varus.
A mere 4 to 6% increase in varus alignment increases the medial compartment loading by up to 20%.
20%.
Imagine that pounding on already soft bone. It just accelerates the creation of that medial tibial defect we just talked about.
So the implication for us, the surgeons, is clear. You have to treat the systemic issue first.
That is the mandate. You have to screen for and treat vitamin D deficiency pre-op. There's a clear correlation between deficiency and poor WOMAC scores after surgery. If you fix the alignment but the bone is still soft, your risk of subsidence and loosening just skyrockets.
Okay, so we've established a compromised foundation. Let's talk about the extreme demands placed upon it. A Western knee, it rarely goes past 110, maybe 120 degrees of flexion.
Our life is chair-based.
Exactly. But for the Asian knee, floor-based activities are not optional. They're mandatory.
This is where TKA design meets cultural anthropology. We're asking the implant to do gymnastics daily. Patients need to do deep squats for toilets, prayer positions like namaz, sitting cross-legged.
Or formal postures like seiza in Japan.
Right. These extreme movements start in childhood, and they continue for life. So if your patient can walk pain-free but can't squat or pray, the surgery is a failure in their eyes.
So what are the actual numbers? Let's look at table 25.1. What kind of range of motion is required here?
The numbers push the limits of what a standard TKA was ever designed for. For a full squat, the knee needs to hit 157 degrees, plus or minus 6.
157.
For kneeling, like in namaz or seiza, you're looking at 144 to 158.
And even just sitting cross-legged.
Still high, 130 to 142 degrees of flexion. So your standard TKA that hits 120 degrees is only meeting maybe 75% of the functional need. That's the basis for dissatisfaction.
And it's not just about getting to 150 degrees, it's how the knee moves to get there. The mechanics of femoral rollback are different.
This is vital. In the established model of Western kinematics, flexion involves posterior rollback, where the lateral condyle's excursion is way greater than the medial condyle. It's asymmetrical.
The lateral side pivots and slides. But the Asian knee has a different pattern.
Yes. The difference is the medial side. The lateral condyle has similar excursion, but the crucial finding is that the medial condyle stays much more stable. It has very little excursion during deep flexion.
So a medial pivot point, essentially.
A stable medial pivot. If your implant design assumes symmetrical rollback, you're going to get kinematic conflict, edge loading, and you'll just shred the polyethylene.
That's a great point. So just increasing the posterior slope of your cut isn't enough. You need the right bearing geometry.
You need to accommodate that medial pivot mechanism.
Okay, so let's talk forces. Is squatting just catastrophically high in terms of force magnitude?
That's a common misconception. The real threat is the direction of the force.
What are the numbers for magnitude?
Squatting exerts forces of about 2.2 to 2.3 times body weight. And interestingly, that's equivalent to the contact forces during walking.
So it's not just that it's a huge force.
No. The nightmare is the shear force shift. This is the key insight.
Okay, explain that.
In normal walking, the tibiofemoral shear force is directed posteriorly. This is good for the tibial tray. It kind of locks it down into the cement.
It's favorable.
But in deep flexion, during a squat, that force completely reverses direction. It becomes directed anteriorly.
Ah, so it's actively trying to pull or lever the front of the tibial component off the bone.
Exactly. It's an incredibly potent mechanism for micromotion and aseptic loosening. It creates massive tensile stress right at the implant cement interface.
And you combine that with the low BMD we already talked about.
And you have a dedicated attack on the integrity of your construct. It's like trying to pry a glued box open from the side. That anterior shear is a killer for long-term fixation.
And we can't forget the patellofemoral joint in all this.
The unsung victim of deep flexion. Post-TKA studies show that kneeling is the single most strenuous activity for the PF joint.
And these patellae are already smaller and thinner to begin with.
So if you don't get perfect tracking and preserve your bone stock, you are setting that patient up for anterior knee pain, or even worse, a patellar fracture.
Okay, so we've got a soft foundation and extreme functional demand. Now let's get into the pure surgical anatomy, where the implants themselves just don't fit. Let's start with overall alignment.
The dogma is a 180-degree mechanical axis. But when you actually measure large populations, most show a few degrees of natural varus. The Asian knee just pushes that boundary.
How much more varus are we talking? Let's look at table 25.2.
Studies on white populations show an average MA of around, say, 0.55 degrees of varus. But in Chinese, Indian, and Korean populations, it's consistently reported as 2.2 to 2.4 degrees of varus.
That's a critical 2-degree difference. It raises that whole philosophical question in the kinematic alignment world, right? If their natural state is more varus, are we right to force them to a textbook 180 degrees?
Exactly. Should we be moving toward a more individualized kinematic alignment for this population? Maybe matching that inherent varus would actually feel more natural to them and improve their satisfaction.
Okay, let's talk sizing. The dimensions of the bones themselves. Table 25.3 is pretty clear that these knees are just smaller.
Uniformly smaller, especially in women. And when you try to fit standardized implants, you immediately run into overhang and underhang.
Okay, let's break down overhang first. Clinically, what does that mean for the patient?
Overhang is when the implant is too wide for the bone. This is a critical failure. It causes pain, limits ROM, and messes up your patellofemoral kinematics. The literature says an overhang of more than 3 millimeters will produce symptoms.
So you're basically creating tendinitis with your implant choice.
You are. And the opposite problem, underhang, is even more damaging structurally.
Because you're not covering the cut bone.
Right. It leads to more bleeding and critically early loosening because you have insufficient support for the cement. So surgeons get trapped, they undersize to prevent painful overhang.
And they end up with structurally dangerous underhang. You're damned if you do, damned if you don't.
And the Korean data on this is just shocking.
Tell me about that study.
Chung and his team looked at over 1,000 TKAs in Koreans. Only 30% of knees had condylar widths that were within 2 millimeters of the prosthesis size options.
So what happened to the other 70%?
60% of all the knees had condylar underhang.
60%. That's a majority of cases.
It highlights the urgent need for manufacturers to make higher aspect ratio components, narrower front to back, but proportionally wider side to side.
Okay, let's move to rotation. This is absolutely critical. We're all taught to use the surgical epicondylar axis, the SEA.
It's the gold standard. And the standard teaching is to externally rotate 3 to 4 degrees relative to the posterior condylar axis, the PCA.
But in Asian patients, that relationship is off.
Sometimes wildly so. Studies show that the SEA has increased external rotation relative to the PCA, sometimes as high as 9 degrees.
9 degrees. So if a surgeon just uses the PCA and dials in the standard 3 or 4 degrees of external rotation?
They're actually internally rotating the component relative to the true functional axis.
By 5 or 6 degrees.
Exactly. And internal rotation is a disaster. It causes patellar maltracking, lateral pain, and instability.
This is perfectly captured by that analogy, the mountain and a mole. I think every resident needs to have this burned into their memory.
It's the perfect visual cue in the operating room.
So explain what that looks like.
The reason it happens is anatomical. The posterior aspect of the medial femoral condyle is just much thicker in Asian knees. So if you correctly follow the SEA to set your rotation, you have to take off a huge amount of bone from that posteromedial condyle. That's the mountain.
And you're just skimming the posterolateral condyle.
Right. That's the mole. If you make your cuts and you don't see that massive difference in resection, you are very likely internally rotating the component. It's a non-negotiable visual check.
Okay, beyond rotation, the overall shape of the femur itself, the bowing, is a huge challenge for our intramedullary guides. Let's start with coronal bowing, the lateral curve.
The incidence is just astronomically high in Asians,
Oof.
44 to 88%.
That's a massive range.
And the severity can be up to negative 23 degrees. This means we cannot rely on the IM rod technique in a huge percentage of cases.
Because a straight rod in a bowed femur won't reference the true mechanical axis.
It'll just follow the path of least resistance down the distal femur, which is already inverse. So your fixed ankle jig is referencing a misdirected rod. Yao's study found that if you did this in femurs, bowed more than 2 degrees.
You got malalignment.
In 31 to 34% of patients.
So 1 in 3 patients are malaligned just because of this. And as figure 25.6 shows, the result is a varus component, which just leads to early failure.
Right. It forces you away from standard IM technique.
Yeah.
You have to use navigation, patient-specific instruments, or maybe extramedullary guides.
Now, what about sagittal bowing, the anterior curve? That's another dangerous challenge for the IM rod.
It is. The mean angles are reported from 3 degrees up to almost 9.5 degrees in some Chinese patients.
And what are the surgical hazards there?
Two main risks. First, the rod gets tilted anteriorly. If you place your component perpendicular to that tilted rod, you risk notching the anterior femoral cortex,
Which is a huge risk for a supracondylar fracture.
especially in osteoporotic bone. And second, if you use a shorter pin, the component can end up flexed, which risks impingement and limited ROM.
Okay, we've established the femur is smaller and bowed. Let's turn to the tibia. The tibial aspect ratio is critical here.
Right, the TML to TAPI ratio. Table 25.8 confirms that Asian knees have a significantly higher tibial aspect ratio. The plateau is relatively wider for its depth.
And that's why standard symmetrical trays cause so many problems. It's that square peg and an oval hole issue again.
The same geometric trap. You undersize medilaterally to prevent overhang, and you leave the front and back of the bone exposed. That underhang causes bleeding, subsidence, and risks osteolysis from wear particles.
Which has driven the need for those asymmetrical anatomic base plates.
An immediate necessity.
Now for the alignment challenge on the tibial side. Tibia vara, the medial curve of the tibial shaft.
Just like femoral bowing, it's highly prevalent, 20 to over 80%. And it completely invalidates our internal referencing with an IM rod.
The failure rate of the standard IM tibial technique here it's just astonishing.
It's catastrophic. We have to remember the COAST study. They looked at Chinese patients with tibia vara. An ideal tibial cut was obtained in only 18% of long rod patients.
18%.
But listen to this. When they used a short IM rod, which is common, 0% achieved an ideal cut.
0.
And 41% had unacceptable malaligned cuts. That's a technique that fails almost half the time. It demands you use an alternative like computer-assisted surgery.
Okay, so given that the axis is so unreliable, what about stem design for cases that need it? Does the offset requirement change?
It does. This is a subtle but vital point. In Western TKA, we often use anterior medially offset stems. But in Asians with tibia vara, the anatomic axis exits the tibial plateau anterolaterally.
So you need an anterolaterally offset stem.
You do. To centralize the component properly.
Yeah.
If the manufacturer doesn't provide that specific offset, you're going to have eccentric loading and risk loosening right away.
Okay, so we have a smaller curved varus high demand knee. We've navigated the obstacles. Let's look at the patella and what really defines success for these patients.
The patella is structurally compromised. It's smaller and thinner. This really dictates your decision-making on resurfacing.
And if we do resurface, the magic number to prevent fracture is 12 millimeters.
That's the threshold. One study found a significantly higher fracture risk with a residual patellar thickness less than 12 millimeters. So your strategy has to be to leave at least that much bone stock.
But bone stock alone doesn't guarantee function in deflection. Tracking is everything.
Correct. The small, thin patella is at high risk for maltracking. So resurfacing often has to be combined with a lateral retinacular release to improve tracking through those deep arcs of motion. If it doesn't track smoothly, the patient gets pain and avoids high flexion, which defeats the whole purpose.
And despite all this effort, dissatisfaction rates remain pretty high.
8 to 15% in some studies. And that dissatisfaction is consistently strongly correlated with one thing.
Restricted high flexion activity.
Exactly. It's a failure to deliver cultural function.
Kim's study gave us a precise list for Koreans, right?
They did. The top severe functional disabilities after TKA were difficulties in kneeling, squatting, and sitting with legs crossed.
All floor-based activities.
Right. And our traditional outcome scores like the WMAC, they just fail to capture this. A patient can score great on walking, but fail miserably at prayer positions.
Which is why we need tools like the validated Korean knee score.
We have to stop judging a high-demand knee with a low-demand scorecard.
So is it the implant design that's failing, or is it surgical technique? Are high flexion implants really better?
The evidence suggests technique is often the deciding factor. Many studies show that improved surgical technique like adequate posterior osteophyte removal, setting the right posterior tibial slope, ensuring central patellar tracking is equally or maybe even more important than the implant design itself.
Right. If you leave an osteophyte, the patient will never get full flexion no matter what implant you use.
Exactly.
Okay, now for the big question on longevity. Does demanding 150 degrees of flexion compromise the femoral implant's fixation?
This was a major concern. The biomechanical stress is severe, and the risk window is very specific. Finite element models, or FEMs, found that peak stress at the femoral implant cement interface occurs between 120 and 145 degrees of flexion.
Why that specific range? Why not beyond 145?
Because below 120, the forces are lower.
Yeah.
Once you get past about 145 degrees, the soft tissues of the calf and thigh touch and act as a bumper. They offload the joint.
So that 120 to 145 range is the sweet spot for maximum leverage and stress on the anterior flange.
It's the zone where that anterior shear force is really trying to lift the component off. The model predicted an unacceptable failure risk in that range.
So since our patients have to use this range, how do we mitigate that risk?
This is where technique proves its worth. A follow-up study showed the risk could be drastically reduced by proper preparation of the anterior cortex before you cement.
Specifically by drilling small holes behind the anterior flange.
Exactly.
So explain the biomechanics of why that works so well. It seems so simple.
It's mechanical interdigitation. When that anterior shear force tries to lift the component, you get micromotion. By grilling those holes, you allow the cement to flow in and create these small internal bone hooks. You're turning that disastrous shear force into a compressive force.
Anchoring it.
You're anchoring it. They showed this technique reduced the predicted failure rate from a terrible 31% down to just 2.6%.
Wow. That's a huge safety margin gained purely through technique.
A huge margin.
This whole deep dive points to a really demanding future for TKA.
Absolutely. The future has to be about implant sizes and geometries that actually match Asian anatomy. Smaller sizes, higher aspect ratios, components that accommodate the rotational bias and bowing.
And as you said, our definition of success has to evolve.
We need to mandate the use of specialized, culture-specific scoring systems like the Korean knee score. If we don't accurately grade function for floor-based activities, we're masking the true incidence of our technical failures.
So let's synthesize this one last time. The profile of the Asian knee is structurally compromised with low BMD, geometrically complex, smaller, more varus, prone to severe bowing, and kinematically engineered for mandatory deep flexion.
And the key surgical takeaways for avoiding failure are non-negotiable. First, rotation. Understand and use the mountain and mole analogy. Use the SEA, not the PCA.
Second, alignment.
Avoid IM rods in bowed femurs or tibias because of those devastating failure rates. And finally, address fixation integrity for high flexion.
Right. We established that traditional scrime systems don't work well here, and that the 120 to 145 degree range carries that theoretical risk of femoral loosening.
So given all that, here's a final challenge for you, the future surgeon. If you have a patient who insists on squatting daily, what is the single non-implant related technique you can do that offers the highest statistical impact in mitigating that loosening risk?
We saw that predicted failure rate drop from over 30% to under 3%.
Right.
The answer has to be optimizing the mechanical strength of the cement interface, specifically drilling those small holes in the anterior cortex before cementing.
Turning that destructive shear stress into anchoring compressive force.
It's a small, low-cost technical detail that bridges the gap between our current hardware and the high-demand reality of the Asian knee.
Attention to that level of surgical detail is what will truly define successful outcomes.
Absolutely. Thank you for joining us for this crucial deep dive. We'll see you next time.